Good morning, folks. This is convening of the Central District Board of Health meeting for Friday, October 15th, 2021. It is 8:30 a.m. I will introduce myself as a presiding chair. I'm Betty Ann Nettleton, representing Elmore County, along with Representative Megan Blanksma. At this point, I will call the meeting to order, and we will take roll call by county, starting with Ada County. Dr. Young.
Jane Young.
Raul Labrador.
Present.
Dr. Cole. Boise County, Commissioner Sturm.
Present.
Well, thank you, Ryan. Elmore County, Representative Blanksma.
I'm here.
Good, thank you. Valley County Commissioner Hasbrook.
Present.
Okay, thank you, folks. And we will proceed with our agenda. Under action items, are there any changes to the agenda, Director Duke?
No change to the agenda, Madam Chair.
Okay, thank you. Proceeding under new business, we need to vote on the minutes from our August 20th, 2021 and September 14th, 2021 board meetings. Are there any additions or corrections on either of those minutes? Hearing none, I would ask for a motion for approval.
So moved.
I'll second.
Okay, thank you. Call for a vote for approval on those minutes, starting with Dr. Young, Ada County.
Aye.
Raul Labrador.
Aye.
Dr. Cole. Boise County Commissioner Sturm.
Aye.
Elmore County Representative Blanksma.
Aye.
Valley County Commissioner Hasbrook.
Aye.
Okay, thank you, folks. Those minutes stand approved as presented. Okay, next on the agenda is a review of our Central District audit by Jordan Swigart. Am I saying your name correctly, Jordan?
You are.
Okay.
Thank you.
Well, thank you so much for being here, and the floor is yours.
Perfect. Thank you very much. Like you said, my name is Jordan Swigart from Swigart John and Associates. We did the audit for the years 2019 and 2020. I'm just going to briefly go over the audit. If you have questions, please stop me. I'm happy to go into more detail. And then we have some slides here. So this first page, it's on numbered page 1 on the bound copies in front of you. This is our opinion on your financial statements. So what this says, first off, these are your financials. This is from your accounting system. We looked at it. We looked at the supporting document and how things were being accounted for and put together. And in our opinion, everything is materially correct. So what that really means is that throughout the year, as you're getting those financial reports, you can rely on those. Those were accurately showing what was going on. I shall go to the next slide here. And then one more. This is your balance sheet here on page 3 of the year. So your financials for the commissioners are a little bit different than you would see for the county because they're done on a pure cash basis. So there's no assets, accounts payable, anything like that. So you can see you ended 2019 with about $2.8 million of total cash. It ended 2020 at 2.6, or about $200,000 less in cash overall for the year. If we jump to the next slide here, and I'm going to jump forward quite a bit in the bound copies to page 14. This shows what actually happened for those years versus what was budgeted for those years. So you can see the top is for 2019. You can see in your budget, you'd plan to bring in about 2.8 million. You brought in 2.9, or just under $2 million less in 19 that was budgeted. And you plan to spend 12.8 million. You spent 12.1, or about $700,000 less than was budgeted. 2020, you'd budgeted to bring in 12.3 million. You brought in 11.5, or about 800,000 less than you planned. And you'd budgeted to spend the 12.3, spent 11.7, or about $600,000 less than was planned for the year. So that's that $800, $600 differences there is what caused the $200,000 decrease in cash overall. Any questions on that?
Never seen that one before.
Yeah, Madam Chair, I guess I would defer to Laurel if she has comments. I'm not familiar with that term.
Laurel, go ahead.
Good morning. Thank you, Madam Chair. No comments or questions for me. I just, as Jordan pointed out, this is a different representation of the numbers than what we present in our normal budget to actual. But he comes up with the same overall conclusion that the numbers are accurate and on track. It's just a different way to represent the numbers from my understanding of it. So I would defer back to Jordan.
So I don't have a slide for it, I apologize, but if you turn back to page 6, I think page 6, it doesn't do the budget actual, but is a little bit more in line with how you are used to seeing it. There shows the actual over actual there. So that second column, you see, I think that's split up more in line with how you're used to seeing it there on column 6. And off the top of my head, I'm not sure what was grouped together to make that trustee, but I can look at that and get back to Laurel with it.
Well, it might just be maybe a mistitle for that, because that sounds like each one of us get a benefit or something. I'm not. And then Laurel, if you're still on, remember last time we talked about moving some of the excess cash that into capital outlay. I think we took it away from undesignated cash. You remember that?
Yes, I do. And I do have our reserve fund report as a part of my financial report.
Oh, okay.
And the audit that Jordan is showing goes through the end of 2020. So we're beyond that now. So the changes
that's
that we
right.
made to the reserve funds wouldn't be reflected in this.
That's right. Thank you for that.
Mhm.
Any other questions? All right, if you want to go to the next slide. So this is, if you turn to page 21, so there's 2 other reports we give on your financial statement. This one here, in the state of Idaho, all government entities, in addition to just doing the financial audit, we also look at internal controls and compliance. And that's what this and the next slide are saying. We didn't have any issues. Looking at controls, we saw evidence where more than one set of eyes were reviewing documents, or we're looking at bank statements where there was good segregation of duties, so we didn't have any concerns there. Now we'll go forward, again, one more slide. This report here on page 23 and 24, this is particular to your federal funds. Because you spend over $750,000 of federal funds, we do what's called a single audit. It just means we look specifically at how those funds are, the controls around them, and how they're being spent. And again, we didn't see any issues. They were all being spent in accordance with the grant agreements, and we saw good controls where there were some good checks and balances to make sure things were being done correct. So we didn't have any findings to report there. And if you'll go to the next page, I think, is there any more slides after that one? This last one here on page 25, this is just a good summary of kind of what we see. So you can see down there that the audit opinion was unmodified, like we said, no issues, and then everything else had no issues to report overall. So just kind of a good oversight that no issues, everything was in order. And I believe that's the last slide. Oh yeah, and then, okay, perfect. So I know that's kind of a high overview there, but any questions for me?
Russ, did you have any CARES Act funding in 20?
I'm sure we would have.
There was about 360,000.
It's all covered under the federal side of it too as well, Jordan?
Correct. In the audit report, if you go to page 16, 17, 18, and 19, I didn't put these on the slides, but those 4 pages, that shows you all of the federal grants, then how much was spent on each of those grants. So in about the middle of page 17, you see COVID public emergency response. There's 360,000 there. And there's possible that there was some other COVID money. The COVID money was split between lots of different funding sources, but that's one that's just clearly all COVID. questions?
Well, thank you, Jordan.
Thank you very much for your time.
Yes, and congratulations to staff for, it sounds like a job well done.
They were great to work with. They got us everything we needed. So no, we appreciated their effort in helping us get the audit done. Thanks.
Madam Chair,
Yes,
I would make a motion that we accept the auditor's report for 2020, 2019 budget.
Second.
second. The motion has been made and seconded to accept the auditor's report for the years 2019 and 2020. I'll take a roll call vote by county, starting with Dr. Young.
Jane Young, aye.
Raul Labrador,
Aye.
Dr. Coles,
Aye.
Boise County Commissioner Sturm,
Aye.
Elmore County Representative Blanksma,
Aye.
Valley County Commissioner Hasbrook.
Aye.
Okay, thank you, folks. That stands approved as presented.
Madam Chair?
Yes,
I
ma'am.
wanted to tell him thank you for the format of the report. It
Yes,
makes it
That's
really
fine.
easy to understand and follow it. It's much different than before, so I appreciate it.
Thank you, guys. Thank you so much for your
Thanks, Jordan.
Yeah, say hello to your dad.
I will.
Okay,
Thanks.
see ya.
okay, proceeding onward, there's a list
Madam
of
Chair?
in-person public comments.
Somebody's got a question.
Oh, I'm sorry.
This is Raul Labrador.
Yes, Raul.
So one of the people who sent in comments did make a good suggestion. They indicated when they're reviewing the minutes of our meetings, they don't know who's voting yes or no on different issues, and I haven't really reviewed them that closely. I just wonder if that is reflected in the minutes when we're whenever we vote.
Not ordinarily. Sometimes we do a roll call vote and record it.
Okay. When we do a roll call vote, I think if somebody votes no, and this is not a good example of that, everybody voted yes on this, I think it would be good to reflect in the minutes if there were dissenting votes.
Understood.
Thank you.
Was there anybody that signed up on the list?
We've had no one sign up to speak.
Okay. Proceeding on with new business.
Madam Chair, this is Raul
Yes.
Labrador again. Just wanted to thank you and the board for being open to having comments from the public. And I think that that's going to be helpful, and it will give the public a lot more trust in the things that we're doing.
Okay, thank you. Under new business, we need a update on the Central District staff changes by our director, Russ Duke.
Sure, thanks, Madam Chair. I just wanted to share a few changes with our management team. So we have a couple of changes. One is Bob Nertney, who had been with us for almost 10 years, retired last Wednesday. And I was just going to say a few words about him. He came out of retirement just to join us for a few minutes this morning. And I just want to reflect back on kind of where we were 10 years ago. We had a lot of, I would call them challenges with our technology as far as the stability and emails and syncing up with, then we had Blackberries and iPhone technology was just kind of coming to the forefront. And I really appreciate all that Bob has done, not quite 10 years, but I will say during that period of time, he created what I would call an impressively stable platform. All of us who work with technology, right, our emails lock up or things don't sync properly, the things I talked about with calendars between a device and between your desktop. And during his time, it has pretty much worked flawlessly from where I sit. And that's not an easy task. He definitely advanced our security. The board has been involved in that, right? We have audits completed that were similar to our financial audit that Mr. Zweigart just presented, where, that we were really assured that what we've done was successful with our backup systems. I'll think about the internal and external customer experience, internal being our staff, and certainly I would hear about it if things weren't working properly, and they have, again, exceptionally well. He oversaw some significant changes with our electronic health record systems. As Dr. Young knows, those don't have a life forever, so we have to swap them out, and that's a big process. The acquisition and implementation and staff training, Bob did a fantastic job. And then one of the things that I had always wanted to do was take advantage of technology for all the inspection work we do. So we do over 4,000 food inspections per year, from the street vendor hot dog stand to the large grocery stores. And that has been on a mobile platform. So instead of doing everything by hand and then having to come back to the office and have it re-entered, it's all entered once by our inspectors. It goes into our database, and that's worked well. And there's some other things that the team is working on that he set in motion, like doing the same thing for childcare inspections. So the last thing I just wanted to say, Bob, I really appreciate the fact that you've always taken a great deal of pride in your work and that of your team. And that has always meant a lot to me. And I always felt reassured to have you at the helm. And so thank you. And I wish you all the best in retirement. And Madam Chair, if you want to give Bob a minute or two to say a few words, I think he would appreciate that. And I know he's generally keeps his words brief. So.
Okay, thank you, Russ. Bob, go ahead.
Well, I spent my career rescuing distressed IT departments, and I thought I would come to Central District at the end of my career and go into retirement. And I have to say that I was quite surprised. It's been, quite a challenge working with, in the past with NASDAQ companies and Fortune 500 companies. And there were a number of challenges, but Russ has always been supportive. He made the commitment to get everything cleaned up and stabilized, and it's been a fun ride. That's all.
Okay, well, thank you, Bob, for all of your efforts, and just wishing you much joy and success in your retirement, and stay healthy and have fun. Thank you.
Thank you.
And so two more people I want to introduce. First is Kent Petzold, and Kent is Bob's replacement. So he joined us, and I will give Kent a few minutes to share his background. And he's not been here very long, so he's probably not overly familiar with our entire operation. But Kent?
Yeah, thanks, Russ. It's good to be here. I'm Kent Petzold. I spent a lot of my formative years in IT with Intermountain Healthcare down in Salt Lake. I appreciate the work Bob's done to put me in a position to succeed and move forward with our IT stuff. So really glad to be here and hope we can continue to build on what Bob started.
Thank you, Kent, and we're glad to have you on the team. And the last person I wanted to introduce that has a more public-facing role is our new Public Information Officer at the front of the room, Rachel Garceau. She joined us. This is your 10th day on the job, and she's definitely hit the ground running as would be expected and required of that position. So Rachel, if you want to share a little bit about yourself.
Sure. Hopefully everybody can hear me from way back here. But yeah, Rachel Garceau. I've been in the broadcast journalism world for the last 20 years. So some of you may know me from getting up really early in the morning the last several years. But I'm out of that world and into communications and public health. And I'm really happy to be here. It's only been 10 days, but I already know the team I work with believes in our vision and our mission and what we do. Really good group of people hitting the ground running. There's no option here because there's so much going on. What a time to jump into public health. But it's a really great group of people. I'm excited to help further all the work that we're doing here. So thanks, Russ.
We have two more two more manager changes with some promotions from former retirements, and I'm going to have them join us in December, and they'll be a little bit more grounded at that time, and we'll be able to share some details about their work. So that'll be coming up in December. So yeah, staff changes, but we're heading in a really good direction with our new hires, as you can see from meeting Kent and Rachel, and that's it for staff changes.
Okay, thank you, Russ, and welcome to all of our new folks on staff. We look forward to working with you. Proceeding on, our next agenda item is discussion and vote on the social media policy by Director Sue.
Okay, thank you, Madam Chair. So this topic came up at the August board meeting, which was a regularly scheduled board meeting. We didn't discuss it in September because that was look at the bylaws and vote on a trustee/executive council member. So based on the direction I received from the board, you had asked me to create a social media policy that addressed the potential concern around us reposting post of other entities. And in this case, it would be for the elected officials. So an example of a repost we would do is if we would get a Facebook post from the governor's office that Governor Little was going to be meeting with AARP to discuss COVID, we would then repost that. And as you know, from probably your own use of that technology, as well as from what our former PIO Christine Myron presented to you in August, that's how those platforms work. As you share information of others, they share your information, and the whole idea there is to get it out to as many eyes as we possibly can. So this is what you asked for. You were going to vote on it today. I did send it out a few weeks ago along with the public health advisory policy that we're going to talk about next. I did not receive any comments from any board members, and I'll turn it back to you, Madam Chair.
Okay, thank you, Russ. The floor is open for comments or discussion on the social media policy.
Madam Chair, I guess my question, Russ, is if you do have a post, say, from the governor on meeting with ARP, it's not a political post, it's just more of a calendar kind of a deal, you're still going to continue with that?
Madam Chair?
Yes, Russ, go ahead.
We have never posted political stuff related to, campaigns or suggesting some type of support one way or another for an elected official. What we take is information from their official capacity, not somebody's elected official or anybody's personal account. We look at organizations. Of course, we're talking about elected officials right now. So if in the case of Governor Little, he was posting that he's going to, go to North Idaho and talk about roads, we don't repost that. The content we repost from elected officials would be related very directly to public health and safety and in their official capacity and relative to our 4-county district.
Because the way this reads, the last sentence, any post, and that kind of restricts you. If we have, well, let's see. All of our health warnings, all that stuff's not from an elected official. Just trying to think how that's going to bite us later on.
How else do you get the information out on those formats or what you're talking, like on Facebook or on whatever, if you're not reposting?
Madam Chair?
Make up your own.
Yes, Russ, go ahead.
Dr. Young, so in the case of, I just use that example because that's one we have reposted a couple different times because the governor does speak to AARP group and the membership about COVID on a regular basis. So if we didn't repost that, that information would not be coming from us. It comes from their account, but back to the point of social media is you take information that you think is relevant and important for the community to hear about public health, public safety, and you pass that on through your own posts so that your followers, people who are following Central District Health that may not be following Valley County Commissioners, would then get that information. So there's not really another mechanism for that content and that medium to get the information out.
Who makes that call here in Health District?
Madam Chair,
Is that gonna be Rachel or who's that gonna be?
that would, Madam Chair, Commissioner Hasbrook, that would be Rachel and her team, Lena Gilmore, who you guys all have worked with for quite some time. So with the content that they, I feel like they've been pretty judicious about it in terms of the content. Actually, Lena went through and looked at former posts, and I didn't see any concerns with that. And certainly, if the board had concerns of us reposting content that you were aware of, then that could be brought forward to my attention.
I guess my point, Madam Chair, sorry,
Yes,
what I'm
sir.
trying to get you is that, as this is gonna be a policy, if we slip and we do post something that wasn't supposed to be posted, I don't feel like that should go into her personnel file as a violation policy. Because it's gonna take a while to kind of figure out, I think, what can and what can't be posted, and I don't want it to come back and bite that employee that's in charge of that. Does that make sense?
Yeah, Madam Chair.
Yes, Ruth.
Yeah, so this, again, it's a draft policy. This is for the board's discussion today. If you want to make modifications to it, we have the ability to do that right now. We have it up on the screen. If there's some portion of this policy, I did it based on what you all shared. It's really straightforward, right? You don't repost content. Now, if you wanted to modify it and say you don't repost any politically associated content from an elected official, well, we'll change it and then you guys can vote on that. So this is just a draft.
Madam Chair,
If I'm sorry, who spoke up?
this is Megan.
Oh, hi, Megan.
Sorry.
Go ahead.
I like the language, and I guess I had the complaint in that there was a post by a mayor in Treasure Valley, and it was about a fireworks show. And so while that's not political, it was limited in what its public health value was. And I still feel strongly that you repost content from elected officials, and we've spent the better part of 2 years dealing with the I can't even say it, to over politicize this public health board. And I think it's important that we not do that. And that was the point of having the policy is to avoid any semblance of being any kind of political entity. And so I think with respect to the director's comment about an AARP governor meeting, for the most part, you can go find that on AARP and repost it from the AARP standpoint rather than the governor's, his social media account. So I just think it's important not to be getting involved in the politics of things, and there's other things that reposts that are specifically directed at public health, and I think that it's important to have a line there, and so I would support the policy as written.
Thank you, Megan. This is Betty Ann. Just looking at this policy draft from a wordsmithing perspective, how would the board feel about striking the first word any between avoid perception here? And on the last sentence, from reposting content from any, striking those words.
The two any's out?
Pretty much, yes. On the last one, state as such, CDH will refrain from reposting content from any elected official social media. So take any post or those three words out of the last three sentences.
Say that again.
Does that make it more?
Seems like it. I'd be first. The content, I mean, taking away the political part of it, but leaving the content part.
Yeah, Madam Chair, I'd be fine with removing the first any, but I'd prefer the second any stay.
Okay.
Madam Chair, this is Raul Labrador. I think you're trying to work with wordsmithing. That's last line, instead of saying from reposting any post, you can say, because you're saying any twice in that sentence, you can say CDH will refrain from reposting a post or any content, or I'm sorry, will refrain from posting no, I take it back. I see what you're saying. I think you're saying reposting any post and then you're repeating any again. There might be some wordsmithing, but I guess we're being too technical too. So I would get rid of the first any, but leave the second one as is.
Okay,
How about, Madam Chair?
yes,
How about the last sentence is from reposting content from and at elected officials?
yes.
That answers my.
Does that sound okay, Raul? CDH will refrain from reposting content from an elected official's social media.
Yes.
How about reposting content? Yeah, I guess I'm okay with that.
And what's the first sentence gonna say now? It's gonna, Board of Health prefers to avoid perception.
Yes, we just remove the
Just
first.
remove the any, okay?
Yes.
So Madam Chair, I'll make a motion, we approve this policy as amended.
Okay, is there a second to the motion as amended?
Madam
Madam
Chair, this
Chair?
is Commissioner Sternmal, second.
Okay, thank you, Ryan. Any
Madam
further
Chair?
discussion? Yes, Megan, go ahead.
Yeah, can you show the edits accurately on the screen, please, so that we know exactly what we're voting on? My understanding is we were also removing the any post or from that bottom sentence as well. So
Yes.
I just want to be 100% clear on what we're voting on.
And change any to an,
Elected official, right?
from
right,
an elected official. Perfect.
Okay with that, Megan?
Thank you.
Okay, thank you. Any further discussion I call for a vote? Hearing none, we'll start with Ada County, Dr. Young,
Jane Young, aye.
Raul Labrador,
Aye.
Dr. Cole,
Aye.
Boise County, Commissioner Sturm,
Aye.
Elmore County, Representative Blanksma,
Aye.
Valley County, Commissioner Hasbrook.
Aye.
Okay, motion passes. The policy is accepted as amended. Thank you. And moving on, we'll have a discussion and vote on the public health advisory by Director Duke. Russ, the floor is yours.
Thank you, Madam Chair. So this was also a topic that came up this past summer about the guidance CDH was issuing. So as you all are aware, or as I've shared with you, what we do is we take information coming from our National Public Health Agency, the Centers for Disease Control and Prevention, and then we evaluate that information and make a determination if it's appropriate to essentially support that guidance or modify the guidance that we've been issuing out to our community. So to be clear, we issue guidance like every day on all types of things, whether it's an individual situation and when to quarantine or quarantine guidance for the broader community, or another example is we're updating our guidance around Halloween, how to safely enjoy the Halloween holiday. So that's guidance. That's just saying to the community, here's what we would recommend that you do, should you choose to keep yourself and your family safe and our community safe. Above that is a public health advisory. So we issue public health advisories. They're very formal. They're more specific. They're still recommendations. They're not orders. They're not mandates. They're not requirements. Looking at you, Commissioner Hasbrook.
Cascade Lake, and you just took it off last week.
Right. Cascade Lake, they had a blue-green algae outbreak, which can be harmful to dogs, to cattle, to people. So during that outbreak, in coordination with DEQ, we issued that advisory. So I did not include that in here. I just made this specific to the COVID-19. That's where this issue has been brought up. And there's a process here. So essentially what I'm asking is to allow us to issue advisories, which we have not. We issued an advisory after the board lifted the orders this past spring. So when the orders were lifted, that's a mandate, that's a board decision, not staff decision. Then we implemented an advisory to make sure that the public was aware of the very serious nature of the ongoing pandemic. I mean, people generally get it now, not that they necessarily respond to our recommendations as we would prefer, but again, they're simply recommendations. And what this policy would describe is we would implement a public health advisory around COVID if we ever did. Certainly you would be informed of that, ahead of that. And then if you chose to, as a board, you could call a special meeting and you could say, direct our agency to lift that advisory. So I think the timing on advisories are pretty important, just like you mentioned with Cascade Lake. If you wait till our next board meeting 2 months from now, it's kind of old news and unhelpful. Our job is to protect public health. So put this advisory together. The difference between this and the social media policy, there is a procedure. This is just following our agency template for policies, internal policies, external policies that we do. And in that procedure, it describes what I just described is we evaluate the guidance, whether it's coming from Health and Welfare or American Academy of Pediatrics or Centers for Disease Control and Prevention. We build that into our own guidance. And in this case, if it rose to the level of an advisory, you would have the ability to call a meeting and basically retract that advisory.
Madam Chair, some questions.
Yes, Commissioner Hooker.
So Russ, just so I got this straight in my head, let's say you have an STD outbreak at Mountain Home Air Force Base. Is that a public advisory to the Mountain Air Force Base that you need to be careful there's an STD? I mean, how does that process work? Because my base question is really, to me, the tough issue is based on science and data. Well, whose science and whose data? And that's where we've been crashing and burning for the last 2 years. Is CDC's guidance? Is it somebody else's personal science and data that came from a study in Switzerland? Or that's where I think we get in the mud, so to speak.
Madam Chair?
Yes, Russ, go ahead.
Commissioner Hasbrook, so this policy is specific to COVID-19. So the STD outbreak would be something that we may issue a public health advisory. Generally, in that circumstance, because it's a relatively contained group of individuals, we would work directly with them. We wouldn't do a public health advisory, but a public health advisory may go out, like if we were seeing, back to the STD situation, not relevant to this policy, but maybe a rapid increase in cases of syphilis among a certain population we couldn't reach out to, we may issue a public health advisory in that case so that our medical community could be looking for that particular disease as they're having patients come in, and then people in that particular community, let's say it's, which happens, right? Substance abuse, non-English speaking, sex for drugs, sex for money. Those audiences aren't very easy to reach always, so we may issue a public health advisory in that case. Or with the plague, with the Columbian ground squirrels, so that the broad community is aware, if you're going to be out in areas where there's Columbia whistle pigs, as they call them, then you would at least be aware. Now, you can go do whatever you want. We're not restricting you. We're just making sure you're aware of it through this very formal process. So back to this really is about COVID. And what we do is we don't take the Switzerland study and do guidance. What we have always done consistently is we use the information coming from our National Public Health Agency. And I know there's some perception, well, this got politicized. Well, we posted content from when Dr. Redfield, the Trump appointee, was the head of CDC. We would take that information, we'd analyze it, and if it's relevant to our community and what we're seeing, then we would send that out as guidance, not an advisory. And the same with Dr. Walensky, who runs the CDC now. So we don't we don't just take information and just, okay, we're sort of like the social media policy. Well, we'll just repost it even though it's not relevant to here. We have a team here of epidemiologists and scientists and medical professionals who would analyze that information before we would issue it. So this, again, this is a public health advisory. It's kind of that step right under public health orders, which you have the authority to do. And it's really specific to COVID.
Madam Chair, Dr. Cole.
Yes, Dr. Cole, go ahead.
So on these advisories, Russ, I'm curious, do you bounce those off of the board members? Is that anything we have input on, or these things that you will put forward? I'm just wondering if we have comment as board members on those. To Elt's point, because I agree, some of what we've received in the past year tends to be behind the time data. So I just want to make sure that these are things advisory wise. I like the concept, don't get me wrong. I just want to make sure, are these things that we as board members will have input on or review capacity at times? Thank you.
Madam Chair?
Yes, Russ, go ahead.
Dr. Cole, so outside of COVID, we have shared the advisories with the board, but not for input. With COVID, that information would be shared with the board in advance of us releasing it.
Thank you.
Madam Chair.
Yes, Raul, go ahead.
So I do have a question, and this is where I think we're getting a little bit confused. I don't think anybody has an issue with the CDH reposting something that CDC posted, saying the CDC and maybe on COVID we should be a little bit more careful, but just saying the CDC just issued this guidance. Where we're having problems is going back to the posting that CDH did. I think it was on July 28th. You went further than just saying the CDC just issued these guidances. You specifically said that the CDH is going to recommend these things that CDC just issued. And that can't be done without a vote at the board. That's fine, whether it's under the Trump administration or the Biden administration. I understand that you have been posting what the CDC is doing, but you've gone beyond just reposting to actually advocating for a specific policy. Just this week alone, Russ, you went to the school board and you advocated for masks for children. I want to know where you're getting that authority, and if that's something that we as a board need to vote on before you're going before a board and telling them that they should be issuing a mask mandate to the children. That's what I'm concerned about. If you want to repost what the CDC did, that's one thing. But when you're going beyond that and you're actually advocating for a position from the CDC, I think that needs to be voted on by the board.
Madam Chair, can I respond to that?
Yes, Russ, go ahead.
Yeah, thanks for your comment, Mr. Labrador. What we did in that circumstance was took the information from the Centers for Disease Control at the time that we were all aware that schools were getting ready to go back into session. They were about 2 weeks out. The Centers for Disease Control identified breakthrough cases, pretty high numbers of breakthrough cases in a state back east of the vaccinated population. So we analyzed that information for all the reasons we know. In a school setting, kids up to age 11 could not be vaccinated. We have a very low immunization rate for the kids who are 12 to 18. We have staff who work at the schools, bus drivers, teachers, school administrators. So it's a high-risk environment, and Lindsay Haskell can talk about that here in a minute. But I guess just to get to the point, we believe at Central District Health that it's appropriate for students, staff, and visitors, per CDC's recommendation and per CDC's data, that they should be masked when in an indoor setting. Certainly not if you're sitting in your office by yourself, and I clarified that with West Ada, the school board that you're referring to. And again, I feel like that's my role. It's a recommendation. It's not a mandate per Idaho code, and I made that very clear to them. It's up to the Board of Trustees of our school boards to make that determination. So the question is for this board, if you want to, that's not an advisory. That's not what we're talking about. That's giving guidance to the community so they can make good decisions. In this case, we have two of our health systems, the two health systems in the Treasure Valley, in crisis standards of care. People who need surgery for things like cancer are not getting it taken care of because the hospitals are full. And that's advice that I provided to West Data School Board for them to decide what they wanted to do. So if the board's preference is every time we issue guidance, I just need some clarity. Is it to the individual who we're asking to quarantine? Is it the school board? Is it the Halloween party? Is it restaurants? So I appreciate you bringing it up, and I'm here, as you know, I work for you, and if you prefer to be involved in all those decisions, then let me know, and we'll do it.
Madam Chair, so,
Yes, Al, go ahead.
you know, this is kind of the stick in the mud right now, because this is what, to me, this is what Russ's job is, to offer advice to people that ask for the advice, whether it's a school district or a county or a hospital or whatever. And if he were to go in there and say, you know what, the CDC says you probably should wear masks, but you guys do what you want, we lose our strength as a public health agency. So I don't feel like I need to be approving everything that Russ does. I think he has that capability and smarts to do that. I know that, you know, if we get enough heat on a policy or we get enough comments, he's already stated if it's an advisory, we can come back as a board and say, you know what, we want to do away with that advisory, or we want to support it, you know, by a majority vote, or however that's going to work. But to micromanage his position on what he thinks is good advice, I think would be a huge mistake and would kind of gut the public health that we've all grown up with.
Madam Chair, this is Raul again.
Yes, Raul. Go ahead.
So are we going to have a discussion today about where you're getting the data about the breakthrough cases? I mean, are they being caused by schools? Are they, is that discussion going to happen later on? Because that's what I'm worried about. Is I understand the standards, the crisis standards of care. I understand that we're having a big issue in Idaho, especially in the Treasure Valley. But how many of these cases are being created by unmasking in the schools? And it just seems like we are following a policy and following advice from the CDC that is just not supported by the data that it's actually bringing down cases. Are we going to have that discussion later on today?
Madam Chair.
Yes, Russ, go ahead.
Mr. Labrador, Lindsay Haskell's our communicable disease control section manager, and she can certainly speak to that when her time is up here in a few agenda items from now. You know, I think what you're talking about with a school setting is like, do kids, maybe you're asking, do kids get COVID? Do kids get sick from COVID? Do kids transmit COVID when they're unmasked and in close contact with others? The answer is absolutely yes, they do. It has been a little bit more challenging when you're getting 700 plus cases reported per day, a large percent of those among youth in our state, to say, oh, it happened in art class between 2 p.m. and 3 p.m. It doesn't work that way anymore. We have widespread transmission. So what we're doing is we're looking at high risk environments. These children spend whatever it is, 5, 6, 7 hours a day, from classroom to classroom in large numbers, and it's a high risk environment. So as I shared with West Data and with any other school board, the idea was, well, we'll look at VSU and look at the stadium's packed. It's like, well, you can choose to do your part to help or not. But I think the science is clear. The data is clear. transmission occurs at school. It occurs with school-related events like athletic events, transportation, on buses. Transmission is definitely occurring. Lindsay can speak to that, but I just wanted to make it clear. The suggestion that kids don't maybe get COVID or can't transmit COVID or don't transmit COVID in a school
I
environment.
don't think anybody's suggesting that. I just think the transmission, we need to know what amount of transmission is happening at schools and because there are dangers to wearing the masks for the children. There's other side effects, psychological and social, and you can't just be looking at one side of the equation. And I think that's what's missing in this debate. And I think that's why we need to have this discussion.
Madam Chair.
Yes, Ross, go ahead.
So, a point that you just made about the dangers of wearing a mask, I will share with you that West Data actually looked at their suicide ideation among their entire school population, the elementary, the junior high, middle school, and high school. And what they actually found, which by the way, they shared it, that all but 2 weeks they've had mask required for the last school year, and then of course the start of this school year there was that 2-week window of voluntary. What they actually found among all age groups is they saw a decline in suicide ideation. Now, one could draw the conclusion that somehow masking helped improve mental health. I don't believe that's true, but certainly the evidence is not there to suggest in their situation with pretty good data that children were being harmed somehow mentally. And so anyway, I don't think there's much data out there on that.
Thank you, Russ. Well, and I've always felt like as a board, we have worked with the Department of Education in conjunction with them and always advocated, we give you the science, we give you the numbers, you make your own decision for your district. And I like that.
Madam Chair, Dr. Cole.
Yes, Dr. Cole.
In terms of the data that we do give them, I'll kind of go back to the point that a lot of our federal agencies have been kind of behind on the data. One of the things I do constantly in my day job is analyze data. So I guess my concern is that when we do make these recommendations, there's a lot of data to be analyzed. I guess I am concerned slightly in some of these recommendations because I know it's a hot button issue in the community. I just want to make sure that we as a board on some of these, and again, I don't want to micromanage Russ. I appreciate what he does. And I just want to make sure what we at least have the opportunity to discuss, based on which data are the decisions made.
Thank you, Dr. Cole.
Thank you.
Further thoughts, discussion?
Madam Chair, so I'm just wondering if we need to add on a sentence on the bottom part that, because it's really going to come down to how you interpret the science and the data. If we have board members that don't agree, we need to set up some kind of a process where, and you kind of have, well, okay, I don't agree with that advisory. Let's get together, have that emergency meeting, and let's talk about it. And let's all look at the data and make that part of the policy. I don't know if that's a wise thing to do or not. I can't make up my mind, but I know in county government, we have to set everything up where if you don't like this person's decision, here's who you appeal to. And eventually it'll end up in district court if you want to go that far. But that's the best part of democracy, is having some place where you can appeal that administrator's decision. And I think that's kind of what we're trying to do here a little bit. To me, this makes perfectly sense the way it's written. I'm just trying to satisfy Raul and Dr. Cole and their concerns about, I disagree with your data, or I don't want to look at your data, and we have a chance to do that before you put up the advisory. Do you have any idea or any way we could?
So, Madam Chair.
Yes, go ahead, Russ.
To me, that would be addressed at that meeting that you would call. There's the process here. majority board members, the chair, certain individuals per your bylaws have the authority to call a meeting. So the content of that meeting could certainly, I mean, I would expect it to be a discussion, not just, well, we don't agree with the data, so let's lift the advisory, but I would bring staff in, I'd bring our scientists, our medical professionals, our epidemiologists to share essentially what the basis is for the public health advisory. And then, we could have the conversation. But what Mr. Labrador is talking about is just guidance in general. This is like straight up guidance. This isn't an advisory. This is debating whether or not maybe that wearing masks is harmful to kids. So therefore, we might want to tell them they shouldn't wear a mask. They're asking me for my opinion. West Data invited me. I didn't invite myself. They asked for my opinion. They asked for my recommendation. And I think it's our responsibility to provide it.
I do too, I
I do
agree.
too.
Yes.
Well, and Madam
Yeah.
Chair,
Yes,
the other
Dr. Eden,
part
go
for
ahead.
me is that based on science and data, we all know that there's a lot of science out there and there's a lot of data out there, and it's how we interpret it and how we put it together, how we make actions based on the information. So it's not, people that deal with it day in and day out are going to have more breadth of awareness to be able to interpret that science and data than those of us on the board oftentimes.
Further thoughts from board members?
Madam Chair,
Yes, Megan, go ahead.
can I ask a completely unrelated question of Russ since he brought it up about crisis standards of care?
It's okay with me, Russ. Go ahead.
Hey, Russ, I was just curious. I had a constituent contact me and they wanted to know where, if there was reporting done based upon who didn't get what care they considered to be appropriate due to the changes to crisis standards of care. And I didn't know if there was a reporting mechanism, whether it is to public health or whether it is to Department of Health and Welfare. Do you have any knowledge on that frontier, or is that something that we could find out?
Madam Chair.
Yes, Russ, go ahead.
Yeah, thanks for the question, Representative Blanksma. So we wouldn't have any knowledge on that. I think you're probably aware as the legislator, the process of crisis standards of care, there's an advisory committee set up at the state, and then they make a recommendation to Department of Health and Welfare Director Jepson on authorizing, and essentially it's allowing the health systems to implement crisis standards of care. And then what we saw happen was it was originally authorized in North Idaho, and that actually public health districts 2 and 1, so all the way down to Reagan's, and then it became a statewide authorization, but then St. Luke's and St. Al's health systems declared that they were implementing crisis standards of care. And that's a conversation then that has to take place between the health systems and state level government, in particular Department of Health and Welfare, to determine when they would no longer need to do that. So I hear what you're saying. This is information coming from our health systems, and I think they are the ones that need to be responsible and accountable for making those decisions and communicating that clearly to our governor and to his staff. So I'm not sure I could get it. I'm not sure who's keeping data on that, but I could certainly try to find out and share that back with the board.
Madam Chair?
Yes, go ahead, Megan.
Yeah, I don't necessarily need you to run it down, Russ. I can call Director Jepson, but if I understand what you're saying, if there's any reporting done, then it would be at Health and Welfare, and it is not in the purview of public health.
Madam Chair?
Yes, go ahead, Russ.
That's correct, Representative Blanksma.
Thank you.
Sure.
Okay, thank you. So I guess at this point, do we just call for a vote or motion or a vote on this as presented, or do we draft this and present it at the next meeting, which is not until December unless we call for an emergency meeting? What's the flavor of the board?
Madam Chair,
Yes, no, go ahead.
I'm gonna make the motion that we go ahead and approve this policy as written.
Okay, all right. Is there a second?
I second it.
Okay, thank you, Raul. Any further discussion before I call for a vote by county? Hearing none, we will start with Ada County. Dr. Young,
Jane Young, aye.
Raul Labrador,
Aye.
Dr. Cole,
Sorry, I was on mute there. I may abstain on this one for the moment.
okay. Boise County Commissioner Sturm. I think Ryan's there. Elmore County Representative
Aye.
Oh,
Sorry.
thank you, Ryan. Representative Blanksma
Blanks my eye.
and Valley County Commissioner Hasbrook.
Aye.
Okay, thank you, folks. The motion does pass and the policy is approved as presented. Thank you. All right, next we have our financial report by Laurel McMahon, our Support Services Division Administrator. Laurel, the floor is yours.
Thank you, Madam Chair. Good morning to the rest of the board. And thank you, Dustin, for getting my screens up. So I'll go over a brief review of the budget, typical to the standard budget review. As you know, this report goes through the end of September, which is 25% of the way through the fiscal year. And just looking at this slide, you can see that our numbers are pretty much on track for where we expect to be at this point in the year. Go into a little bit more detail on that. Our revenues are at 28% of budget, so slightly over that 25% of where we'd expect to be this time of year. And expenditures are also very close at 22%. If we look at the top, the revenue section, looking at the fees, total fees are at 20% of budget. We expect over the next couple months that FCS fees will pick up due to some of the flu clinics and revenues coming in there. And then as a reminder, community environmental health is heading into their busy time of year with fee collection for annual food licensure. So we expect to see that number picking up percentage-wise over the next couple of months as well. Looking at the contracts section, you can see that our revenue is slightly high here at 30% of the budget already. And that's, again, close to where we'd expect to be for this time of year. For other revenue, so you can see that support services is right on track. For CEH, a reminder there that the revenue is always high this time of year with Millennium Fund, CRP, and WICHC funds from the state. So pretty standard to see that higher percentage at this time of year. And then for FCS, the other revenue shows high there from state home visitation. So again, what we'd expect to see there. Brings our total revenues to that 28% that you see at the bottom of the top half of the screen. And then moving into expenditures to go into a little bit more detail there. You can see that our overall personnel budget is at 21%. We do still have COVID temps on staff, and we have some of our regular staff charging to COVID funding streams. But this year we were able to do a better job of planning where those numbers would be and how they would look. So we're closer to where we plan to be, not the level of variance that you saw at this point last year when we were still accommodating to some of those changes. Looking at operating here, we can see that the total amounts at 28%, again, slightly above the planned amounts, but well within where we expect to be at this time of year. Our capital expenditures are only at 4%, and that's because, as I remind you or talk about almost every month, we haven't finished that last phase of the remodel yet. The furniture, carpet, and paint that we have, the 4% that you see there, that almost $10,000 was spent on a water heater. So that came out of the capital funds, and we still have the remodel money set aside there. Again, looking at January to February timeframe to finish that final phase, assuming that we'll have more space in the facility at that time. Moving on to page 2, and this is our year-over-year comparison. You can see the fees here, looking at them from a different perspective. Comparing over the last 3 years, you can see that the environmental health programs are all pretty close to where they were this time last year. Sewage disposal is a little under where it was this time last year. And as a reminder here, we're still seeing increases in our environmental health fees, even though we were able to lower the fees this year. So that's a good thing across the board there. And we see, again, the continuing trend of upward fees in FCS this year, and that upward trend has been ongoing over the last couple of years. We do continue to receive our Medicaid revenues for our behavioral health services, and you can see that continued increase in home visitation. And then we can move on to page 3, the cash balance statement. And this reflects the changes that you made in the fund designations during our last meeting, our last August meeting. So just a quick summary of this page, we see that the cash balance statement shows the total cash of over 7 million. Reducing the cash balance by the reserve fund designations, we get to that undesignated cash balance of 1.2 million. And that will continue to dwindle down over the next few months, and then we get the rest of our appropriation. That cycle will be standard with the changes in the funding that we will have starting in March of this year. And then we'll look at different funding cycles as we go ahead into next fiscal year. I wanted to make one note about the special projects and the carryover designations that you can see here just as an update since our last meeting. So some of the things that we designated money for, the admin assistant that we designated a half of FTE for has been hired and has started in their role already. So that's on track. The grant writer has also been hired and will start later this month. So you don't see any change in those in the designations yet, but we'll continue to see those over the next couple months or start to see those. And then the other update I had on those special projects is that the FCS marketing project has just begun. So that's in the planning phase. And then the campaign that you've set aside money for will continue over the next couple months and should get kicked off. I'm sure we'll have updates on those as it progresses. And that is a summary of our budget to actual and cash balance statement. I'll stand for any questions.
Thank you, Laurel.
Madam Chair.
Yes, Commissioner Hasbrook.
Laurel, I appreciate you breaking out the reserve fund designations. I think that's going to pay off big time later on when we get into the legislative session. So thank you for doing that.
You're welcome.
Any further discussion or questions for Laurel? Okay, hearing none, we thank you, Laurel, for your update, and we will move on to Lindsay Haskell for COVID review status. Lindsay?
Good morning. Trying to get off mute and start the video. Looks like it's not working. I apologize for that. I am going to give an overview of where we're seeing our health district with current COVID levels right now. Please advance the slide, Dustin. So this is a look at our total cases in district by county and by year and deaths. So we've seen a dramatic increase in cases since I last presented to you. The last numbers were from August 17th, and since then, we've had more than 20,000 cases of COVID reported, and that's about half of the total cases reported in the entire year. We went from 525 deaths to now that 765 number. So 240 deaths have been reported in the last 2 months, and that's 30% of our total for the entire year, or 30% of our total deaths since COVID began, and over 60% since the beginning of the year. Next slide. One of the indicators we're always looking at is percent positivity, and we see that we hopefully peaked or appear to have peaked with our percent positivity at 16% back in mid-September. We are approaching the same mark as when I last presented to you. It was 11.2 in August, and now we're back down to 11.9. So things are going in the right direction with percent positivity. Ideally, we want to see that percent positivity under 5, as we did in the spring and through the summer. Next slide. So this is total cases reported throughout COVID by week in our health district. We had a peak I'm hoping our highest week was the week of 9/12 through 9/18 with over 3,800 cases reported, which is much higher than we saw during our winter surge, with our highest week being 3,358 cases. Right now, we are experiencing a backlog in data from the amount of cases and reports we're receiving every day. We have approximately 1,500 electronic lab reports still to be reviewed. Health and Welfare is assisting us with those. They are assisting with a few of the older cases, approximately 400 between the weeks of 9/19 and 9/26. And then we are working on about 1,100 labs from the last 10 days. So the week of 10/3 and 10/10 still aren't current. We anticipate with those numbers, those last 3 bars on this graph, to increase, but not increase above that high week of 9/12. Below that, we have the graph of the age breakdown of cases. And the thing to note here is the 0 to 18 range. It used to be our lowest bar or second to lowest bar when we were looking at these graphs. Now we're seeing that the 0 to 18 range is increasing at high rates and approaching being our second highest group of cases. We also know that this age group is not fully eligible for vaccination and has the lowest rates of vaccination in those eligible. So those 12 to 18 account for, have less than a 50% vaccination rate. The goal to have is vaccine rate that we would like to see is over 70%. When we look at our population overall, we're at 62%. So again, that 0 to 18, or who's eligible, that 12 to 18, only less than 50% have been vaccinated. This is a graph specifically for Ada County. And you'll see again that highest rates we saw that week of 9/12 with 3,400 cases and higher than we saw in previous surges. The next graph is for Boise County. And again, September being very high, much higher than we saw previously. The week of 9/5, there was 52 cases and still remaining higher than we saw in many other times. For Elmore County, we're seeing that this surge has been particularly high or higher compared to previous. Week of 9/5 was the highest with 287 cases reported. And for Valley County, the highest peak we had was in January of 2021. So lower numbers during this time by week, but many more weeks of high numbers. So still experiencing a surge in Valley County. Another data point I want to talk about is hospitalization. This year, we've had over 1,100 residents hospitalized with COVID. Total, we've had 2,794 residents with COVID hospitalized. This particular graph shows just the PHQ-4 residents by day, and it's census data, so it could be the same person that's hospitalized September 1st, 2nd, 3rd, 4th, but showing that we're having much higher numbers than we saw previously for hospitalizations and ICU admissions, but starting to notice a downward trend. These graphs are by week, and it is total patients in D4 hospitals. The most recent week posted is for the complete week beginning 10/3, October 3rd, and we're starting again to see that decline in hospitalized and ICU admissions, but still much higher levels than we've previously experienced and continuing to cause strain on the hospital systems and healthcare system. Some of the additional information and hot topics I talked about last time was vaccine breakthrough. On that second bar, you'll notice an error. The number should be 4,832 is the total number of vaccine breakthrough cases we've had as of 10/8 when the data was available. Much higher than I presented in August when it was 1,058. We also saw a large increase in hospitalizations and deaths. As we've experienced higher cases, we've experienced more vaccine breakthroughs, but the proportion of vaccine breakthroughs to cases has remained level. So we're seeing, as we see more cases, we anticipate more vaccine breakthroughs, but it's not, vaccine breakthroughs are not increasing. And in the state of Idaho, right now, it shows that unvaccinated individuals are 4 times less likely to be infected with COVID than an unvaccinated individual, and a vaccinated individual is 5 times less likely to be hospitalized if infected with COVID. Also wanting to speak to the changes we're seeing with age groups and deaths and hospitalizations. You'll see we have not had any deaths in individuals under 18 reported due to COVID. They are starting to monitor stillbirths in those that, in pregnant individuals that had COVID. That data isn't fully available yet, but will be something I'm hoping to present on in the future. And you'll note hospitalizations definitely highest in the older age group, but seeing hospitalizations even in our pediatric patients. In 2020, 4% of COVID cases were hospitalized and just over 1% died. In 2021, we're seeing less hospitalization percentage, down to 2.8, and that's showing just for that, with where our hospital systems are at, that maybe other areas have a higher percent hospitalization, and that we have that many more cases happening at one time right now. We did see a decrease in the case fatality rate from 2020 to 2021, but it has increased dramatically recently. So when I presented in August, our case fatality rate for the year was under 0.5%. So it was 0.43. Now we've doubled to that 0.89%. And that number is, again, likely to increase due to we're still going to continue to receive electronic death records and reports. And we received notification that there's a backlog in that reporting as well due to resources at the level of, I believe, vital statistics and some of the county areas. So Ada County and Valley County have a case fatality rate of less than 1%. Elmore and Boise County are just over 1%. And for kind of reference, right now we're receiving about 300 cases a day is our average, down from over 700. If we're looking at that, that's a week of 2,100 cases per week. So we anticipate 18 to 19 deaths per week with these numbers. This information can be found on our data dashboard, Health and Welfare data dashboard, and the CDC COVID tracker. We recently updated our data dashboard. It is done on Mondays and Thursdays, and we're doing, or we've added different tabs, so we're not duplicating data that's presented in other ways through Health and Welfare and CDC. So overall, our indicators may have peaked. We're continuing to monitor, but all things continue to be much higher than we'd like to see, and we're still in high transmission. So we're not out of the surge quite yet, and watching closely, we're seeing increased deaths, increased hospitalization, and increased cases in new age groups, including those that are more likely to be affected, more susceptible to illness, unvaccinated, and monitoring that closely.
Madam Chair,
Yes, Russ.
I would like to ask Lindsay to speak to some of Mr. Labrador's questions about schools, if she would take a few minutes to do that, just to make sure you guys are updated on what we're seeing.
Did you hear Russ's request, Lindsay?
Yes, I'm happy to do that. Thank you. So with cases and transmission being as high as it is, we're unable to contact trace in every case, and we're unable to pinpoint necessary or exact exposures. But we're looking at, we prioritize contact tracing in those that are in school or unable to be vaccinated. And what we're learning is students are in school and spending a lot of time in school every day. So it is a higher risk in that's where they spend a lot of their time every day. We have found that some schools aren't contact tracing, so we're not able to determine transmission if it's occurring. And we also know, especially based on recent studies, that kids can get COVID but are more likely to be asymptomatic, and without surveillance testing or testing of all of those that have been exposed, it's hard to know the true rates of transmission. We know that we are seeing an increase in that younger age group, school age group, than we've seen prior in any of the surges. And other studies that are being done in other areas have shown that in schools without masking, they're over 3 times more likely to have an outbreak, and that a study of over 520 U.S. counties looked at incidents in pediatric cases in school districts that had masking and no masking requirements in place, and pediatric incidents case rates were higher in those school districts that did not have masking. We also have data that Dr. Peterman with Primary Health has shared, and his percent positivity data looking at pediatric cases coming in for testing in their facilities. The percent positivity among those tests in school districts that have optional masking or no masking requirements in place are much higher than those with mask requirements. And they did report with West Data specifically that after masks went from optional to required, they saw a percent positivity decrease among West Data students coming in for testing. We also know that with the quarantine recommendations, masking helps for increased in-person learning. And there's been some additional studies we've looked at that indicate universal masking can reduce risk of infection in a school setting by 26 to 78%. So looking at all of those things, that is mirroring what data we have available to us, but it is limited due to some schools not contact tracing and us being unable to contact trace with every case coming in.
Madam Chair, this is Raul.
Yes, Raul, go ahead.
Lindsay, what study are you relying on? Because the CDC study that hasn't been reported on a lot actually showed the opposite, that there was no difference between masking requirements and unmasking requirements. And I know that the study that Dr. Peterman relies on actually did not have a control group. They only studied a district that had masking requirements, so they made some assumptions that were not based on a control group. So what study are you relying on?
So there's
Yes.
several different studies that I referenced. Two of them most recently were published using CDC MMWR, and I can share those. One was done in Arizona, and then one was done in 520 counties in the U.S. Those both came out through CDC. And then there's a couple others that came out through different journals.
Because the CDC report did not show an appreciable difference between masking requirements and school districts that didn't have mask requirements. So is there a new study? Because this is news to me, and maybe you can send that to me.
Yeah, I would be happy to send a list of resources that I'm using.
Thank you.
Madam Chair, Dr. Cole.
Yes, Dr. Cole, go ahead.
Thank you. To Raul's point, yeah, there are large studies out of North Carolina, Scandinavia, et cetera, that, really well-controlled ones that showed no benefit as well. So I just wanted to add that. I do have a question going back to the COVID data. When you're tracking breakthrough cases, in the UK, when they track data, they track breakthroughs post 1 shot and then breakthroughs post 2 shots. And they don't count those in the unvaccinated category. Are we tracking those here in the county, the individuals that aren't counted as fully vaccinated 2 weeks post their second shot? I'm just curious if we have that data set here compared to what other regions of the world are counting for a true comparative with full data.
So we are using the standard case definition for vaccine breakthrough case as somebody that is fully vaccinated. So the data I'm presenting is somebody that is 2 weeks post whatever that full vaccine is. Is it the 2 doses, the 1 dose, if it's the Janssen vaccine? And so the data I present is on that. However, we do look at individuals' vaccine status and have that. It is data that could be ran to look at if they've only had 1 dose of a 2-dose series and if they were infected and outcomes. But it's not data we're currently running, but it is data we have.
Okay, yeah, and I'm curious on that one because I think one public health message that we do miss there is after that first shot, I think, unfortunately, we see a lot of, just from immune modulation, those individuals that are actually at a slightly higher risk during that period of time. So I'm just wondering if that should even be a public health message to let those individuals know. I think a lot of people get a shot in the middle of the quick spread and say, oh, I got my shot, I feel protected. So to your point, if we have that data, it would be interesting to look at, because I think, just an educational point of view that helping those individuals know, or if we were able to see that data, the higher risk of actually acquiring COVID in that window, I think it could be helpful from just a public health point of view. Thank you.
Thank you.
This is Raul again. I do have a question, and it's about a state statistic, but I think it applies to the presentation you just gave. We keep hearing, and I especially, I don't know if everybody has this issue, but every time I'm on Facebook, I see the same ad from the Idaho Department of Health that 98% of people that are receiving, that are dying or have COVID have been unvaccinated. But that statistic seems to be a little bit misleading because we're counting all the cases from the beginning of COVID till now, and the vaccine was not available until December of last year. Do we know what percentage of people have actually had breakthrough cases versus new people unvaccinated? Is it 98%? It seems like it would be a much lower number. I don't know if you're understanding my question, but seems to be a little bit misleading when we say 98% of people were unvaccinated, because 100% of the people that had COVID until December were unvaccinated.
Correct. That is a great point and a great question. When Health and Welfare is sharing the data with us at the health district level or on calls and presentations I've been a part of, They factored that in, and those numbers, when we hear 5 times or 4 times, those percentages, they're actually looking at after May, when all adults or everyone in that population was eligible and could have been fully vaccinated. So they are accounting for that in the numbers they're sharing.
Thank you. That's very helpful.
Madam Chair, this is El.
Yes, Al, go ahead.
Lindsay, I had a question on the graph that talks about deaths by age group. Is this just data for 21, those deaths, or does that include back into 20? Because we've had, what, 3,200 deaths in Idaho, and those numbers don't add up. That's what I'm trying to get to the bottom of.
So that is numbers for our health district since we began tracking COVID. And I didn't share, but since you asked, I do have it, excuse me, in front of me, that I looked at, oh, let me grab water. The average age of death in 2020 for our health district was 76.5, and for 2021, we're down to 73 years old.
So that's just for our district. You don't have to have the statewide for all the districts, do you?
I do not. Health and Welfare does display some of that data on their website, but I don't believe it's broken down by county.
Okay. The other thing that, I guess this is more of a general statement, and I want you to confirm or deny me, but it seems to me like really what's happening is the masks have kind of slowed it down in the beginning, and that was kind of the goal of the mask, was to slow it down so our hospitals didn't get overwhelmed and reach critical care where we are now. And then it seems to me too like this new variant is maybe less contagious but more dangerous. Does that seem appropriate?
Yes, it's hard to compare in some ways 2020 to 2021 because we had the introduction of the vaccine, but then we also had the introduction of the new variants. What we're finding with the Delta variant is that it is more transmissible and can be more severe. And what we're also seeing in 2020, we had, the stay-at-home orders or different practices in place, and we were seeing more mitigation in the community than we're now in 2021. We see less mitigation, such as requirements of masks or masking. We're having large events and new things, so it is hard to look at 2020 and 2021 in the same way.
Thank you.
Any further discussion points for Lindsay? Well, hearing none, Lindsay, we thank you for your presentation, and hopefully this decline will continue. So at this time, Dustin, are you there?
Yes, I'm here.
Dustin, I'm going to call for a 15-minute break at this time, so we will reconvene at 10:20.
All right.
Okay, thank you.
I should have told you, I think there's food in that room over there for you guys.
We're live.
Okay, thank you.
Oh,
Dustin.
yeah, we know the breaks.
I know.
Okay, we're reconvening our board meeting, and we will proceed with Natalie Bodine's vaccine status and distribution update. So Natalie, go ahead.
Thank you, Madam Chair, and good morning to the board. I'm going to be providing a review on our vaccine planning and distribution, looking at some highlights on vaccine approvals and guidance, and then looking at our latest vaccination rate data for our 4 counties in our jurisdiction. Next slide, please. So some highlights since we've last met and presented in mid-August. So right before our last Board of Health meeting on the 17th of August, the FDA had approved a 3rd dose of an mRNA vaccine. So this would include Pfizer and Moderna for those that are moderately to severely immunocompromised. And then on August 23rd, the FDA gave full approval for their first COVID vaccine, Pfizer, which is now to be marketed as Community for use as a 2-dose series for individuals 16 years of age and older. And it can also continue to be used under the emergency use authorization and those that are aged 12 to 15 years. Then on September 22nd, the FDA amended the emergency use authorization for the Pfizer vaccine to allow for a single booster dose to be administered at least 6 months after completion of the primary series. Next slide, please. So moving on to September 24th, so just 2 days after the FDA gave approval for the booster, CDC made further recommendations on administration of the booster dose for Pfizer under that FDA emergency use authorization for some specific groups. Those groups included people 65 years of age and older, residents living in long-term care settings, people 50 to 64 years of age with underlying medical conditions, people 18 to 49 years of age with underlying medical conditions, and also people 18 to 49 years of age who are at increased risk of exposure because of occupational or institutional settings. And CDC further detailed their interpretation of that increased risk of exposure to include first responders, which would include your healthcare workers, firefighters, police, etc., education staff, which would also include our daycare workers, food and agriculture workers, manufacturing, corrections, United States Postal Service workers, public transit, and grocery store, and said that this list could also be expanded at any time. And at this time on the 24th, with that recommendation, boosters did not apply to Moderna or Janssen. Next slide, please. And then just this week, so yesterday and today, the FDA Advisory Committee has been meeting. Yesterday, they discussed the emergency use authorization of the Moderna vaccine for the administration of a booster dose following completion of the primary series to those 18 years of age and older. And yesterday, at the end of that meeting, the Advisory Committee did unanimously recommend a lower dose booster of Moderna for seniors 65 years of age and older, and those that are at high risk due to underlying conditions or due to their jobs. And then today, the FDA Advisory Committee will be discussing the emergency use authorization of the Janssen COVID vaccine for an administration of a booster dose to individuals 18 years of age and older. So we will be watching to see if there was any kind of recommendations that come at the end of the day from that meeting. Next slide, please. So taking a look at an update at our current vaccination rates across our 4 counties. Again, this is data that is coming from the Idaho Immunization Reminder Information System. And the data that you're seeing today is current through the end of day on the 12th, which was Tuesday. So this looks, of course, Health District 4, Central District Health is right in the middle, showing 60% of our 12-plus-year-olds are vaccinated. as of Tuesday, and that it includes fully vaccinated or received at least one dose in a 2-dose series. So the dark green bar shows percent fully vaccinated. So that's 62% for Central District Health, which is just over 282,000 persons. And the light green bar shows percent of those that have received at least one dose in a 2-dose series. And that is sitting at 5% for our jurisdiction and just over 22,000 persons. Next slide, please. So this is taking a look at vaccination rates by county. So I'm going to do some comparisons and looking at what I last reported to our Board of Health in mid-August. But currently, Ada County is sitting at 69%. In mid-August, they were at 63%. Boise County is currently at 34%. In August, they were at 30%. Elmore County is currently sitting at 42%. In August, they were at 36%. And Valley County currently sitting at 67%. And in mid-August, they were at 62%. So continuing to make slow and steady progress in increasing those vaccination rates across our jurisdiction. I also, of course, want to mention in Elmore County that rate does not include those that are vaccinated on Mountain Home Air Force Base. I did receive some information through Lindsay, who was able to touch base with them, and Mountain Home Air Force Base is reporting that they are nearing 100% vaccination rate in their active duty, with last shots expected this week. So anyone who has access to their facilities on base, which may include their families, contractors, etc., can receive a vaccine from them. Next slide, please. So the last slide on data takes a deeper dive into doses completed by age group. And again, this is for our jurisdiction, so includes our 4 counties. And you'll see here again that just pulling out a couple of different age groups, of course, age 65 plus still has our highest vaccination rates, with the 75 to 84-year-olds, the highest age band within that group. And again, they have also been the longest age group. They have had vaccine available to them since early February 1st, so they're sitting at 90%. And looking at our 12 to 15-year-olds, which were approved on May 10th, currently sitting at 41%. Next slide, please. And that concludes my presentation, and I'll stand for any questions.
Chair?
Yes, I'll go ahead.
Oh, Ryan, go ahead.
Madam Chair, yeah, real quick question. Can you confirm the Comirnaty, the one that did get approval, can you confirm whether that's available in the state of Idaho?
So my understanding is that the Pfizer vaccine that is going to be marketed and labeled as Comirnaty will not be shipped out to the states until end of October or early November.
Thank you.
Madam Chair?
Go ahead.
Natalie, just real quick, you know, I've had a lot of people talk and ask me about, no one's keeping track of the natural immunity, people that have gotten the disease and gotten over, never got vaccinated. And I know it's almost an impossible number to trace, but certainly there's got to be a rough estimation. If we're at 67% and let's say 20% are naturally immune to it, doesn't that help our herd immunity? Do you have any comments on that?
Madam Chair?
Yes, go ahead.
Unfortunately, I do not. I don't have any of those numbers. I could certainly ask our partners at the local and state level to see if there's anything out there that may have some information around that.
Well, if I can continue, Madam Chair, the question or the concern I'm having is people are asking me all the time, since I've already had it, I don't need the shot. And I don't really know how to respond to that. Can you give me some advice?
Madam Chair, Dr. Cole, I could comment if you
Yes,
don't
Dr.
mind.
Cole, go ahead. Go ahead.
Yeah, natural immunity, COVID recovered, is a much broader immunity, much more durable, long lasting. this virus is almost 80% similar to SARS-CoV-1. We know those individuals 18 years later that have been tracked still have immunity. This should be a third category within our society and our counties that acknowledge that that's the best immunity of all by far over a vaccine immunity. And to your point, Elt, a high percentage of our individuals in our county have had COVID, and giving a shot to an individual, if you look at the studies of Dr. Rao, Dr. Kammer, Dr. Mathudius, and there are 3 other studies, vaccinating a COVID recovered individual puts them at a higher risk of adverse reactions than baseline. So the COVID recovered, giving them a shot can actually adversely affect those individuals. There's no good science or data to indicate that a COVID recovered individual needs to be vaccinated from a medical point of view. Thank
So
you.
if I can continue, Madam Chair?
Yes, go ahead.
Dr. Cole, what are the symptoms of somebody that does get vaccinated after having the virus? I mean, what does it actually do to them if they've already got an immunity?
Oh, some of them will get severe reactions. You can get fever, obviously just your basic shot reactions, but some individuals will end up with, you can get something in immunology called high zone threshold, where you already have an antibody, and which is good. And antibodies aren't the be all end all. Your T cell memory is far more important than your antibodies over time. But if you get a shot, you already have antibodies, you can actually ramp your antibodies too high, and you can get some immunologic dysregulation. The other individuals, I mean, there's smaller subsets where people will actually get, similar myocarditis. Some other individuals will get neurologic conditions. And you're modifying a broad natural immunity and selecting for a spike immunity, which can be less broad than your natural COVID recovered response. So you can actually favor a narrower focus of immunity as well over time. So again, in the COVID recovered, there's no medical evidence that a COVID recovered individual needs to be boosted unless, they're a high risk individual who perhaps has a weakened immune state. If there were breakthrough cases in the COVID recovered, we would see medical reporting by the thousands of breakthrough cases. That simply does not exist in the medical literature because it's simply not happening. And if you look at the commentaries of the most published medical author on COVID, Dr. Peter McCullough, he has over 46 publications on COVID this last year and a half. He says you cannot look into all the medical literature and find a case where the virus has been sequenced twice in a breakthrough case in a COVID recovered individual. So a broad natural immunity, we need to be acknowledging that. We need to be not pushing vaccine campaigns for those who've had COVID and recovered. And another very important aspect is if somebody is recently convalescing from COVID or getting a shot and they don't know whether they're either brewing COVID in their body at this time and or have recently had COVID, those individuals, we really need to have a screen before vaccine program, because those individuals are put into that risk category of severe reactions during that window in which they have COVID and get a shot, and or if they've recently recovered from COVID and get a shot.
So Dr. Cole, this is Betty Ann. If those people are screened that are considering getting vaccination to see if they have the antibodies, is that being pushed as a program? What do we do?
I mean, I don't know that it's being pushed as a program. I think it's a very medically prudent approach to take. I know Dr. Nordchasm out of University of Pennsylvania, or at least he's in the state of Pennsylvania. He's pushed that and he's very pro-vaccine, but he's pushed that very heavily. And he talks about basically the clotting reactions that can happen in those who have COVID at the time they get a shot, and or those who convalesced and really aren't far out of the window of having had COVID when they get a shot. He's documented an increased risk of vascular injury in those individuals. So I think it would be prudent to have a program that if one chooses to get a shot, it would be medically prudent to make sure that we're screening so they don't fall into that higher risk of adverse reaction category.
So Madam Chair, this is a quick question, Dr. Cole. Is that just your standard COVID test, or is that a different test?
It's a different test. You're looking at a blood test for antibodies for one, and if one thinks they've had COVID and recovered, And antibodies always wane over time. They go to a quiet level. Doesn't mean you don't have immune memory. Your antibodies drop with any infection in the human body over time. There's also a T cell test. You can look for T cell memory and the genes that have been turned on in your T cell line of immune cells as well. So there's two different blood tests that can be done to assess those individuals.
So my question again, Madam Chair, to Natalie is, these people that have passed away in the hospital, have they been tested for this kind of reaction? They came in, they got a shot and it made them sicker and they ended up in the hospital? Do you understand my question? Natalie, are you still there?
I am still there. Yes, sorry. I do, and I cannot answer that.
Because honestly, I keep hearing about, I think I had it back in March, or I had it back last year, and I think I'm okay because I already had it. But you didn't get tested, so you don't really know if you even had coronavirus. You might have had the flu, or you might have had food poisoning or something else. And that's where I think we're losing the connect with people, is that I've already been through this, I've already had it, I'm pretty sure, I'm okay. Well, you really need to go in and get an antibody test, it sounds like, to make sure that it was coronavirus in the first place. So that might be something we need to look at as a board down the road, that if we want people to get vaccinated, they're gonna have to get this test first. I don't know, I'm just thinking, long term, I think that would pay off. Oh, I can't make up my mind.
Madam Chair.
Yes, Russ.
So I just wanted to weigh in, like everything COVID seems to be, there's, the recommendation is for people who have recovered from COVID, who are unvaccinated, to get vaccinated. So I can have one of our staff speak to that in December and share the research on that. I know Dr. Cole cited some studies appropriately that would suggest there's potential, or maybe high potential, for harm that can occur from that. But I would just share that the current recommendation is people who are COVID recovered, once they've recovered from the illness, that they get vaccinated.
Can I comment to that, please, Madam Chair?
Yes, please. Please do.
In the history of virology and immunology, we generally don't do this to people who are recovered from viral diseases. Once a patient is recovered, we don't. If a kid has had chicken pox, we don't give a chicken pox vaccine. If someone's had measles, we don't give a measles vaccine. It really, unfortunately, counters science and basic virology to be vaccinating people that are recovered from illnesses. So again, if we were having breakthrough cases in the COVID recovered, we would see it replete within the medical literature, and it is literally absent. Because it's not happening from any statistical significant point of view. We're seeing, the vaccines now don't prevent acquisition nor transmission. And we know studies out of the University of Wisconsin just recently show that the vaccinated are carrying equal or higher viral loads of virus now, because these vaccines were for the legacy variants that aren't even circulating anymore and don't Delta as well. They were formulated for the wild type strain Wuhan from many variants ago. So those who have had COVID have a broad natural immunity that form antibodies against all proteins in the virus. So to vaccinate someone, again, it just doesn't make scientific sense. And I like Elt's idea. I mean, if we're going to be using resources wisely, to be vaccinating those who have had COVID, it just doesn't scientifically make sense whatsoever.
So, Madam Chair.
Yes, go ahead.
So, Russ, I would like to get that on the agenda for the Decembers, and let's have a really hard discussion with some help here to kind of explain everything to us, to make sure we're going the right direction.
Glad to do that.
Thank you.
Thank you.
Thanks, Dr. Cole.
Madam Chair, this is Raul.
Yes, Raul, go ahead.
And I think it's important to know what Elt said, and I think Dr. Cole would agree with this, that people need to know, just saying that you had COVID is not by itself sufficient. I think there should be some sort of test to determine whether you had it. or not, and that would be helpful to prevent the misuse of the vaccines. But I think Dr. Cole would agree that just somebody saying I've had COVID without any proof of it is probably not the safest route for that person to go to make a medical decision for themselves.
I concur. Thank you.
Yeah.
This is Betty Ann Lindsay, and Natalie, I want to thank you for addressing the Air Force population, since that is approximately 1/3 of our county's population, and so our numbers should be significantly better than as reflected in our data. So thank you. Any further questions or discussion for Natalie? Jane?
Madam Chair, I just had one for Natalie. I want to thank you for your prompt response and how quickly you get back to people and answering questions and making it possible for those of us out there doing it to do it. Thank you.
Happy to do so. Thank you.
Okay, Natalie, thank you so much, and hopefully our numbers will be better by the time we meet next time. So proceeding on, we're going to have a Region 4 Behavioral Health Board update by Laura Smith. Laura?
Yes, thank you, Madam Chair. I'm going to share my screen here so that you can see my slides. So I'm Laura Smith. I'm the Health Policy and Promotion Program Manager with Central District Health, and I'm going to give you a brief update about our behavioral health situation in Region 4, as well as the activities going on to address it. So I want to preface this by saying that there is a whole lot that we could discuss about behavioral health. We could talk for hours, so this is going to be fairly high level. Also, the activities that I will talk about within CDH are specific to my health policy and promotion team. We, of course, do have additional activities in the Family and Clinic Services Division. So a quick snapshot of behavioral health in our region. In 2018, individuals in our counties reported more poor mental health days than poor physical health days. In 2020, we had 97 suicide deaths, and there have been approximately 2,400 ED visits related to suicidal ideation in 2021. In 2020, our region experienced the highest rate of suspected drug overdose related to visits presenting to emergency departments. And from 2018 through 2020, across Idaho, drug deaths reporting synthetic opioids increased by 9%. So all of this may sound like really bad news, and it is certainly not the trend that we would like to see, but we do have a number of activities working to address this. And so I'll go a bit into that now. So as folks may recall, CDH, like all public health districts in the state of Idaho, facilitate a member-run or volunteer-run regional behavioral health board. This is mandated in statute as a 23-seat board, and criteria are defined for each seat. So this is an example of some of the seats that are held within our Region 4 Behavioral Health Board, and likewise in the regional boards across the state. So these boards have the mission to improve behavioral health by developing solutions in our community through an integrated behavioral health system accessible to everyone. Their role is to advise on local behavioral health needs, advise on the progress, problems, and proposed projects of the regional services, and to promote improvements. As CDH, our role is to make sure that those members can meet, that they can discuss these issues. We serve as a liaison to DHW, providing reports from the board to the state, and as the fiscal agent. But the activities of the Behavioral Health Board are determined by the membership themselves. So the board has taken on a strategic planning session over the last few months, and they came out with 3 high-level topics to address. So enhancing services and supports. Some of what they're really interested is in enhancing family services, peer network services, and addressing issues like homelessness and all of the ways that affects folks going through behavioral health crises and issues. They're also interested in promoting and providing information and education. That is on an individual member basis, of course, and also supporting community activities and events. And then enhancing the infrastructure of the board to make sure that we have all of those members at the table, and is also partnering with community members who, while they aren't necessarily a member of the board, do attend meetings on a regular or semi-regular basis and contribute to the good works of the board. As a part of what's mandated in statute, they submit a gaps and needs report to the state on an annual basis. That is a summary of all of the areas that membership has identified as needing some additional work in our communities. And then also annually, they reply to a Department of Health and Welfare questionnaire. That questionnaire is sent to each board member individually, and is aggregated across the entire state to also address the planning council at the state level. So in the report to the state, as I said, they're identifying gaps in available services. They're assisting the Behavioral Health Planning Council, which addresses the Governor's Committee for service system improvement. And then they annually provide a report to the Behavioral Health Planning Council, the Behavioral Health Centers, and the State Behavioral Health Authority, Department of Health and Welfare, on its progress towards building a more comprehensive system. So some of their current efforts, they're developing a trauma-informed care conference. Last I heard, they were nearing full capacity for that conference, which is really exciting. They will be able to offer CEUs, so continuing education credits for behavioral health practitioners. They are also working on an electronic Rolodex of membership and interested partners. This will help them to be able to connect across their different services, across their different organizations. The board has also set aside a pot of funding to allow for mini grants. So organizations from the community can apply for a mini grant. Some recent examples is we had a community college in Valley County apply for a mini grant to help with an education campaign and outreach campaign on mental health. We have also helped with some smaller peer recovery programs in Ada and Valley counties as well. And then finally, one of their big efforts is providing scholarships for the Idaho Conference on Alcohol and Drug Dependency. That's a very high quality conference that happens on an annual basis, and there's always a lot of interest, and so this will facilitate additional practitioners attending. So the Behavioral Health Board fits into a very detailed network of partners, and so wanted to share this maps just so everybody could understand where the board sat, where CDH sits, and so forth. So over here on the right-hand side in dark blue, we have the Region 4 Behavioral Health Board. They have 5 subcommittees and 1 work group. And the Behavioral Health Board as a whole interacts with CDH on a very regular basis. Again, we're serving as the liaison and fiduciary. They report to the Idaho Behavioral Health Planning Council, who then reports to the Department of Health and Welfare. That is all in the name of giving additional recommendations to the governor and updates on progress. Separately, you may have heard recently about the Idaho Behavioral Health Council. That is a new council that is being run by the 3 branches of state government. And they have a very detailed strategic plan, which I'll talk about in just a little bit. But these 2 entities do have very similar names, and so I just wanted to make it very clear that they are separate entities at this point. Within CDH, we also have our own activities. I'll talk a little bit about these in a minute, but I also want to make sure that everybody understands that this is, again, just a part within health policy and promotion. So the Idaho Behavioral Health Planning Council, again, this is the group that the Behavioral Health Board reports to on an annual basis, is meant to provide oversight to the Region 4 Behavioral Health Board, as well as the 6 other across the state, fulfilling the reporting requirement to the governor, educating legislators, and conducting that environmental scan of readiness and capacity within the system. All of this is meant to create a seamless behavioral health delivery system, and that mission is very similar to the Idaho Behavioral Health Council, but the two entities are intended to function differently, will continue to do so, and overlap will really be on an individual basis from my current understanding. So on that other side, the Idaho Behavioral Health Council was established in 2020. Their vision is for adults, children, and their families who live with mental illness and addiction to receive behavioral health care services when they need them. Really, the goal of the group is to identify the silos and work to overcome them. We need to create a continuity of care, a system that can be navigated by individuals and offer a return on investment of public resources. So they'll be looking at all of the various state authorized behavioral health components and really just making sure that the systems are built up in the different ways that they need to. There's a 43-page strategic plan, which I would invite everybody to look at. It's very well done, but they're just getting started. So we don't have a whole lot of insight into what's going to happen. The Behavioral Health Board actually just had a presentation from this council yesterday, and the idea is that they will function pretty autonomously with a lot of input from individuals and behavioral health organizations, but there is not a lot of intention for them to collaborate with behavioral health boards outright. That would be on an individual member basis. At the same time, as I mentioned, we have our complementary behavioral health programs within CDH. So as a quick reminder, we have our drug overdose prevention program. That program has been doing a lot of outreach and trainings about overdose prevention, naloxone, and supports. Our suicide prevention program works with the Behavioral Health Board's Recovery and Wellness Subcommittee. They work very closely with the State Council for the suicide prevention program as well, identifying strategic objectives at the state level and what those mean for the region. Our Partnerships for Success program is a grant program from the Office of Drug Policy and is focused on substance use prevention, mostly primary prevention, I might add. So a lot of youth supports, a lot of social emotional learning is happening right there. And then you heard from me recently about our Valley County Opioid Response Project, which, as a reminder, addresses prevention, response, treatment, and recovery. So with all of that being said, there's still a lot of behavioral health work to be done. And so we are looking forward to adding another little activity, and I put little in quotation marks, but another activity for behavioral health system coordination. So this will really be CDH's opportunity to build on those gaps and needs that have been identified by the Behavioral Health Board. Because the board is member volunteer run, they don't necessarily have the capacity to act on engaging to address those gaps and needs all the time. So CDH will be able to take that on, take some of those lessons learned and really move forward with them. It will also give us the opportunity to really stay attuned to what's happening with the new Idaho Behavioral Health Council, translate maybe some of their lessons learned, their conversations into local action, as opposed to leaving just at the state level. And I think Russ will talk about the system coordination a little bit more at some point with you all, but we're really looking forward to being able to dive deeper into it. So some of those complementary behavioral health activities, that system coordination, we really want to look upstream. We really want to look at getting to people, supporting families, supporting our communities before behavioral health becomes crisis, before it becomes a need for treatment and care, although that is certainly absolutely part of the plan. So looking at a continuum of care, going from those secondary prevention programs to tertiary prevention programs onto recovery. Lifelong recovery certainly is a part of that as well. Right now, our behavioral health system in many ways is very siloed. It can sometimes be burdensome for providers to navigate, much less the patients. And so we really want to be able to support our communities, our organizations, and our individuals in navigating the system, making it clear, making it something that is navigable and successful for everybody. And then, of course, identifying pertinent data to track over time. We'll always need to have that evaluation component. Right now, behavioral health in Idaho and in our region is very data heavy, but maybe information poor. And so how do we track those specific pieces of data to make sure that we can understand the improvements that are happening? So what will our behavioral health system coordination look like? As I said, we'll be building on that gaps and needs report, coordinating projects from and with those various entities. So from the board, from that behavioral health council, working with our community organizations, serving as a central point of communications for behavioral health in the region. We already do get so many questions about behavioral health. And so it's really making sure that we have that information and know how to address them and to help them navigate and building those systems so that individuals can navigate for themselves. And then, of course, working with groups not currently represented on the Behavioral Health Board. While those 23 seats are very important and very essential to the world, it does not include things like our homelessness community, some of our disability serving communities, perhaps our refugee communities. So there are some other groups that could be really impactful that are not currently working with the board. And so we really look forward to those opportunities as well. And with that, I'll take any questions.
Laura, this is Betty Ann. We're all hearing about the huge volumes of illegal substances pouring into our communities. And at a law enforcement engagement, does your program include city, county, and state levels of law enforcement?
At this point, we are working most closely with county level, Elmore County and Ada County, Valley County and Boise County as well, but we've been working closely with Ada County and Elmore County, and then some of our cities as well. State level, we have various contacts with them, but I would not say that we work with them on a regular basis.
Thank you.
Madam Chair?
Yes, Al. Go ahead.
Laura, a couple of questions. The program that we were talking about years ago when I was on the board about, I can't remember the name of it, but it deals with inmates that are about to be released from the state pen, where we get them some training, get them a job or maybe a place to live. Is that program still offered? Do you know?
I'm not sure if it's coming to mind based on your description. The first thing that comes to mind is our law enforcement assisted diversion program. That is not something that's very common in our region, but we are having many conversations with interested entities.
And then my other question was, with the amount of suicides that we've had, is there anyone that has gone in and basically interviewed the family or interviewed, members of that person's life to see if there's a reason why? Tracked it down to, is it an income issue? Is it a substance abuse? Is anybody looking at that? I think the only other person that ever sees a suicide is usually the coroner, and that's kind of the end of it. It would be nice if we knew a little bit more about if 50% of them are from fentanyl use or, hydrocodone use or alcohol use. Maybe we could, spend more energy on that. In fact, I'm just wondering if that was something that has ever been done.
I would have to look into that myself. I would say that the vast majority of suicides are not necessarily attributable to one reason, but we do have a number of post-vention resources. That's typically what we talk about after a suicide death, is post-vention. We do have a number of resources in the community who are supporting families, are supporting survivors and so forth. So I'll have to look into that and would be happy to have further conversation at another time.
Thank you. I appreciate your answer.
Madam Chair, Dr. Cole.
Yes, go ahead, Dr. Cole.
I just want to thank Laura. I think this is one of the primary health issues of our time. So I want to thank her for efforts in putting this presentation together. And I look forward to CDH being able to, work closely with all these organizations and being a key player, because this is absolutely critical. So thank you so much.
Thank you. We have a great team working.
Wonderful. Thank you.
Any further discussion or questions for Laura? Well, hearing none, I echo Dr. Cole's gratitude for your efforts, Laura, and look forward to hearing our engagement and progress.
Thank you for your time, Madam Chair.
Okay, going on. Russ, would you like to tell us about the state opioid settlement and agreement?
Sure, yes. Thank you, Madam Chair. So state of Idaho sued a couple of the manufacturers of opioids, and their nearing the conclusion of the settlement agreement. And as unfortunate as the circumstances were, the good news coming out of it is the public health districts in the state of Idaho is expected to receive approximately, this is in total, $800,000 a year. So that money will be divided among the health districts. And as I give you these numbers, I will say for sure it is subject to change, but we're getting close, possibly in the next month or two, to having that agreement signed. There will be a formula that will decide how the money gets divided among the health districts, but it won't be a decision of the Board of Trustees. So it's going to be outside the hands of the public health districts to decide how that gets divided up. So to me, it's a big deal. It's good news. It'll add to our work efforts, the things that Laura just talked about. The one factor with that we're going to have to bring before the board, will bring before the board maybe as early as December, is the actual settlement agreement will need to be signed by our board chair or on behalf of Central District Health. So as soon as I get that document, I'll share it with the board via email, and then we'll put that on the agenda for discussion purposes. And essentially what it's going to say, it'll probably take about 40 or 50 pages to do this, but is you're not going to sue them in the future for harm done to individuals. So it's going to look a lot like the 2000-2001 Millennium Fund tobacco settlement agreement. Fast forward approximately 20 years, and that's where we are today. So just kind of an update, a heads up, and more information to follow.
Madam Chair, if I could add that just a little bit, we were kind of notified of this at IAC convention here a couple of weeks ago, and if I remember correctly, Russ, the state gets 40%, the counties get 40%, and the health districts get like 20%. The issue is, just like the Millennium Fund, you can only spend that money on opioid education. And we've kind of talked about, how's the county going to do that? I mean, we can support maybe a treatment facility. It just depends on how far you want to go. We're all in still a lot of discussion, but there is a possibility that the counties could contract with the health district to do that for them. So some of that money could also come in too as well. That's kind of what I've been thinking about with ours. There is a group up there. I think we have 17 providers now for substance abuse treatment that are talking about they need a facility, a building, which they can bring a central located, that we can bring folks to that through bus passes and all that kind of stuff to get them treatment. But that's going to be $1 million, $2 million, $3 million. You know what that's like. So we're kind of talking about those issues as well, but it's very restrictive on where you spend those funds.
Mm-hmm.
And I think, Russ, this was just one company. The way I understand it, there's other companies out there that have made this stuff that they haven't even started negotiations yet.
That's my understanding as well.
So there might be more coming later on.
Right.
So hopefully this formula will be weighted.
Or will be.
Well, it'd be interesting to find out if you could, who's going to make that decision on how that's split up, especially for the health districts.
Yes.
I would love to be involved in that, or at least be there at that meeting. Hopefully it's done on a population basis and not just an acre basis or 7 ways, because that doesn't seem to make sense either. But so I don't know, if you find out, would you let me know, and I'd sure be willing to come down here.
Absolutely.
Yeah.
Okay, Russ, anything further on that?
Nothing further.
Dr. Colorado, Megan, any comments on the opioid settlement?
Madam Chair, this is
Madam
Representative Smith.
Chair. Go ahead, Megan.
Go ahead, Megan.
No, if my guess is that the opioid money will have to go through the legislative appropriations, but I will double check that.
Okay. Dr. Coles?
No, I'll just wait for the details once the settlement comes in. I agree with El. I think it's interesting, the lack of facilities we have. I know there are many facilities, but with the growth of the region, I like Elt's idea down the road. Like having facilities available, it's going to be important. So thank you.
Thank you. Okay, moving on. There's a CDH County Commissioner meeting topic for the spring of 2022. And we previously had an opportunity to have legislators participate in our board proceedings. And that was not really very successful. So I think Russ was wanting to get the board's opinion on should we go ahead and maybe take that to a county level. So Russ, would you like to comment?
Sure. Thanks, Madam Chair. So as you noted, I think it was last year, year before, probably the year before, pre-COVID era, we had organized an educational session for legislators within who are in our 4 counties to come and join a board meeting. And we had really low participation, so we didn't do it last year. COVID, besides it seemed like an effort that didn't bear fruit. So this subject came up, I think, at our August board meeting, where there was a suggestion that we could consider doing something similar, except it would just be for the 12 county commissioners within our district. So I put this on the agenda just for discussion purposes, so we can get some direction from you all if this is something you would like to do, when you would like to do it. Do you want to coordinate it with a board meeting or have it be a separate event? Would it be, day a week, things like that? So probably the first discussion point is to decide if that's something you would like to move forward with, and then start talking about the details so that we can prepare.
Madam Chair.
Yes, go ahead, Megan.
Thank you. If I remember, this was also part of the discussion of no longer doing the Idaho State Board of Health type meeting and instead concentrating on the counties because the funding stream has changed so drastically. Is this part of that discussion, Russ?
Madam Chair?
Yes, go ahead.
Yes, thank you, Representative Blanksmith. That was part of the discussion, was to focus on our specific region rather than the statewide association meeting. But that, that's another part of the discussion, is if we were no longer going to participate in those, which, by the way, we're hosting this coming year, then that would be we'll have to figure out that transition.
Madam Chair.
Yes, Al.
Megan's right. When the counties are going to take over funding the health districts starting March next year. And at the time, I felt like it'd be really great to have kind of an orientation for all the commissioners to come together and kind of see, maybe tour the facility, look at, what we do here. But honestly, I don't know if that's going to work. I think we might have better luck if we maybe send out staff to each county at a regularly scheduled county commissioner meeting and explain to them, maybe show them, the assets that they have in their county that are health district owned, and attack it that way. I just don't think you're going to get 12 guys in the same room at the same time. There is an opportunity in, I'm going to say February, when we have our winter commissioner meeting. It's usually down at the Riverside in Boise, that we could maybe get them all together then. But the issue, we just had a fall conference here, and there was a great many of them that weren't there, even at the county commissioner fall conference. So not sure that's going to work either. But my feeling right now is I think we get more bang for the buck if we just went to each individual county, schedule it on their agenda, and sit down and give them, ask for at least a half an hour or 45 minutes and see if there's any questions, explain. I think we'd be better off that way. Some counties can afford to send commissioners, some counties can't. They have the budget to pay for travel and hotels and all that. So just a thought.
Sure. Oh, sorry,
Okay, thank you.
Madam Chair.
Yes, Megan, go ahead.
So along that line of thinking, have we considered maybe just polling the commissioners and asking them what they'd like to learn more about so that we're not spinning our wheels? And if the answer is we think you're doing fine, then we spend less time on this topic.
That's a great idea. Sorry, Madam Chair.
Yes, go ahead.
That's a good idea, Megan. We could do an online survey of the 12 commissioners and see if they even would be interested in coming down, a doodle poll or something like that to see and find out what they're interested in and see where that goes before we make that final decision.
I think that's an excellent idea also. Any further discussion? Russ, do you want?
Madam Chair, I'll
Yes.
I'll make that happen and report back to you at the December 17th meeting.
Great.
Madam Chair?
Yes, go ahead.
Megan, would it be a good idea to invite any legislatures that are interested in coming to that meeting as well? Do you think is it worth it?
Well, I think that since we're moving toward independent funding, I don't know that legislatively that's helpful. I don't know, I don't know that it's all that helpful, but you could certainly, there are some that'll go to meetings and there are some that don't go to meetings. And I guess I'm biased in that I'm one that doesn't just like meetings for meeting's sake. So I don't know that I'm a good metric for the rest of the legislature, but yeah, unless there's like specific issues or topics, I think that you want to share with the legislature that you're looking for some sort of legislation or movement on. I don't know that just having them down to see what the facility is or just what we do is worth your time, particularly since you don't have to ask them for funding anymore. Does that make sense?
Yep.
Yes. Yes. Any more comments? Before I proceed on, Raul, are you still there?
Yes, I am.
Okay, as a point of clarification that you
Yeah.
brought earlier in the meeting, our administrative assistant, Donna Mahan, did come in and tell me that she does record each individual's vote if there are no or an abstain vote. So yes, that is recorded.
Okay, thank you. I just hadn't realized which way we were doing it, so I appreciate that information.
Okay, thank you. Okay, Russ, do you have anything further to add to the director's report?
I do. Just one item, kind of a follow-on to what Laura spoke about. So I'll start by sharing some thoughts on our reserve fund balances. So there was always the idea of we wanted to get to the point where we had a 3-month operating reserve. So what that 3 months is if we had zero revenue coming in, we could continue to offer the same programs and services for a period of 3 months. So I understand I came from the Legislative Services Office. It's always been a target that we talked about. And then on top of that, well, we did get there, I should say, because of the COVID money. So offsetting the county and state revenue coming in, we typically had spent all of that. Well, we did not because we were able to charge the federal contracts. And then in addition, we had the issue with what we call the indirect rate, remember, and that's where we moved that money. We had it set aside as a potential for your consideration to leave that because we know our indirect rate is going to increase this year. We're spending less time coded to COVID across the agency. I'm not talking about epidemiology and public health preparedness. So what I'm going to propose to you now, just as an idea for your consideration, is there's 2 things I would like to do with some of those funds. One is to fund part-time behavioral health positions. So this would be a full-time position, but have part of their time funded through reserve funds to focus on behavioral health. So when Laura listed out, I think it was one of her last slides, as far as actually coordinating services and figuring out like what you just described, Commissioner Hasbrook, with the opioid settlement money. So we have a very patchwork system, and anybody who's ever served on the Region 4 Behavioral Health Board knows that, and also knows that there's a lot of discussion takes place, but not a lot of movement in any particular direction because of lack of funding. So this is something I would like for our agency to do for a period of time, right? That's one-time money we're talking about, reserve funds. this is a small portion of that that I would be asking for, and I'll explain the mechanics behind that, is the money that we get today is very prescriptive, whether it's a Valley County Opioid Response Project or work on, general drug prevention. It says those are contractual arrangements, so we must do in order to get paid. And this would give us a little bit more flexibility to essentially start working toward implementation of the work that we know we need to do for our community. So as Dr. Pohl noted, behavioral health is a hugely significant public health issue, but there's never historically been a lot of money being put into that. So that's one. The second one is our Parents as Teachers program. So we talk about children's mental health and anxiety and suicide. Is our funding has gone to two programs. One is infant and early childhood mental health. That's one person deep, and that is very specific to a licensed counselor working with a family with a young child who has a mental health diagnosis. So that's been a good program. We're using some of the state general fund that we receive to do that work. And then we have our Parents as Teachers program, which is an excellent program, and it's an evidence-based program, and that's working with basically pregnant women and young children, teaching parents parenting skills, right? Not everyone is born with the ability to be excellent parents. They have lots of struggles going on in their lives, maybe financial, substance abuse, mental health themselves, physical abuse. So we have that program up and running. And the one that I would like to propose, I got to put the budget together and put a plan together to present to you, is Nurse Family Partnership. So Nurse Family Partnership is also an evidence-based program. It's working with similar families, but it's structured different. These are bachelor's prepared RNs who go into the home and work with families. And this is everything I just described is voluntary. Nothing is required, but we've had really good uptake. We get referrals from like Head Start and child care centers and primary care providers and pediatricians. So I would like to offer that as well, because the things like vaccine rates and breastfeeding rates and ready to learn when they get to school and less likely to have interaction with juvenile detention as the children age is a really big deal. It's as basic prevention as you can possibly get. So the mechanics part of it is we're going to do a budget revision in February. That's what we always do. Our budget is a plan that gets approved in May, ultimately by the county commissioners in May. It starts July 1. So I'll bring more detail to you in December to use some of this one-time funding, partly for the behavioral health position, a larger amount of money for Nurse Family Partnership. And again, being one-time funding, we have to have a sustainability plan, right? Because that revenue is not ongoing, but that's something that we're going to work on and something I'm really interested in doing. And for those of you who've been around a while on the board, you remember a number of years ago, Central District Health actually brought in some speakers. Patricia Kempthorne came in and talked about Nurse Family Partnership, but it's a pretty expensive program, and you can always talk about the ROI, but the ROI doesn't come back to Central District Health, so we have to figure out how to fund that, right? The ROI is more community-based. So I guess I'm maybe not asking for your approval, but just letting you know this is what I'd like to do would be bring a plan forward in December for your approval to build that into the budget revision in February, unless you feel very strongly collectively that don't waste your time. We won't, and if you're agreeable to at least listening to what I have to offer, I'll bring that back in December.
Madam Chair.
Yes, sir.
Years ago, when we helped put together the mental health board down here, to me, it felt like we needed someone to take that whole thing on and coordinate it. An advisor, someone that could actually do the legwork. We would come up with ideas about, we need to find a list of all the providers for substance abuse in the county. Let's get them on a website or so people know where to call and that work wouldn't get done. This is, to me, is something that this person could do.
Right.
Is to kind of get the information together, make it available to folks. I think it's awesome. The other one, I haven't heard about the nursing one. Of course, I've heard a lot about parents as teachers. And my support 100%, but I want you to keep in mind that all 4 counties want this. This can't be just an Ada County thing, because now you're dealing with other commissioners for your budget, so you gotta keep that in the back of your mind, that these guys are gonna support this if they see something going on in their counties. Does that make sense?
Madam Chair?
Yes, for the trust.
Absolutely. That's our plan for both behavioral health position, obviously, to be all 4 counties, and also for nurse family partnership. And I don't know if I had shared with the board in the past, I believe I had, like with parents as teachers, because that's contract funds, health and welfare. It's no longer that way, but it was for the first couple of years. It was only for Ada County. So we either sign a contract and use it for Ada County, or we don't get the money. So anytime we use what we call district funds, which will soon transition to almost all county funds, then that gives us the flexibility and latitude to do the things that we know is necessary, which is you don't exclude counties, because there's no county in this district or in this state that doesn't need to, wouldn't benefit, I should say, from the home visitation services.
Madam Chair, a couple more comments, then I'll shut up.
Yes, go ahead.
I think as far as the coordinator for the mental health board, to me, there's a lot of opportunity for funding and grants, but we have nobody that's applying for them. So they're gonna, to me, they need to work with your grant writer, because I think there's a lot of federal money. There's even some state funds that nobody's applying for. The other thing that I think we need to start thinking about, and I'm not saying it's got to be done right away, but I know the governor's been talking about a little bit lately in the news, is we need to figure out a way to bolster childcare. A lot of the folks that aren't working can't find childcare, so that's why they're not working. And I think it's an issue of maybe a little bit of over-regulation on whether it's the state side or the federal side. I'm not sure where those coming from, but there's a lot of expenses, the licensing, all that kind of stuff. But childcare is a huge issue in Valley County, and I don't know what it is down here. I don't know down here, but up there, we have a lot of county employees that can't work because they can't find daycares. So that should be, to me, is a social economic an issue that we need to start working on and keep in the back of your mind too down the road. My own personal thoughts. That's all.
Thank you. So it is the wishes of the board that Russ bring forward a draft of this on this issue in December.
Yes.
Dr. Cole, Megan?
Yes,
Raul?
I think it's great.
Okay,
Thank you, yes.
thank you. Okay, that brings us to the conclusion of our agenda today. If nobody has anything further, I will ask for a motion to adjourn.
Madam Chair, this is Commissioner Sturm. I'll make that motion.
Thank you, Ryan. I appreciate that. Is there a second to the motion?
Second.
Thank you, Jane. I'll take a vote by county, starting with Dr. Young.
Jane Young, aye.
Raul Labrador
Aye.
and Dr. Cole.
Aye.
Commissioner Sturm.
Aye.
Representative Blanksmore.
Aye.
Commissioner Hasbrook.
All right.
Okay, motion passes, and thank you, everybody, for your participation. We will be meeting December 17th at 8:30 a.m. And thank you for the public that is listening in. We appreciate your interest. And so have a wonderful weekend, everybody. Thank you.
Thank you.